Good morning. Welcome to EMS Office Hours. I am Jim Hoffman.
I'm Josh Knapp.
And I'm Dave Brenner.
I want to welcome anyone who's popping in here. We shall see a few minutes. We get some eager EMS people to jump in at 10 o'clock in the morning. This is usually a little earlier than what we normally get on here, but I know Dave and I prefer the early time.
Sure.
Right. And I'm a night owl.
And the other thing we have to remember, it's 7 o'clock in the morning in California.
Well, I was just, and it's 7 o'clock in the morning. So in California, they're just logging into whatever 911 terminals they have. In New York, they got their first call, probably wolfed down a ham and cheese on a roll with a ham and cheese and egg on a roll. And
fourth cup of coffee.
I was going to say finish their first cup of coffee.
I said on their fourth. Oh.
Yeah. From 7 to 10. Yeah, maybe. Yeah.
And our international folks in Iceland and Greenland and on the continent, they're midday or mid-afternoon.
Yeah.
You laugh, but I remember when I did the EMS webinar thing that I did, where we had speakers all day long, all broadcast, online. And I remember looking at the stats, and there were people from Iceland that had looked in on the videos and stuff, which I thought was pretty cool. They were watching it live, and we were, doing it live with the speakers, and also, just good to know people from all over kind of tune in here and there. So guys, I don't know if you guys had a chance to look at the links that I had sent you.
Not the links, but I'm a little up on the topic a little bit.
Oh, okay. Yeah, I guess it's it's not. I can post it in the notes here. Just give me a sec. Let me just post it in your notes so that you guys can maybe take a quick peeky poo.
For everybody there, Dave is our resident expert in everything. So,
please.
Right.
That he's already familiar with the topic that Jim just saw and cut and paste.
Well,
right.
Ketamine's not news. I mean, not brand new, but it's a lot of people don't know about it. But yeah.
Yeah. So
that's true.
And really, transgender stuff's not brand new either. So.
Right. Okay.
Yeah.
Okay.
Well, what I'm trying to get here, I'm not sure if you guys are getting that link or not.
Yeah, I'm getting it.
Okay.
And, I'm a little bit familiar with, I've read up a little bit about this. Obviously, it made the news.
Yeah. What I wanted to talk about, what I'm trying to get at with this topic, and this is actually another one if we have some time to kind of cover as well, a surprise topic. It's a surprise. But this one here, we were talking about the paramedics that were charged in the death of I guess it was a guy who was under arrest. They're being charged criminally for him dying. And I'm wondering, and I've seen some comments on this and on Facebook and stuff like that people get concerned that charging paramedics for something like this in a criminal way might have providers hesitating treating patients unless it is 1,000%, black and white, what they're going to do, or there's no risk in that medication, for a patient. And, ketamine, there's risk with that. And, it seems like they were trying to treat this person for
excited delirium.
Excited delirium, right? Couldn't do the freaking thing. So trying to treat him for that is what they were doing, but I guess that wasn't really what he was having going on. Well,
it was a really problematic. There's two ends that I want to address right off. It's really problematic because the papers take this and, you know, it's not a common situation for EMS to be involved in, you know, this sort of over policing ideology that's coming out. But the other side is that there are critical facts that we don't know, that the papers don't know, and that we won't know until it hits the court. And even if it hits the court, we may never know. So there are aspects of you weren't there, you know, so shut up. And then there are the aspects of, you know, what would the parts that were out in the paper were it felt very one-sided. I mean, from what I read in the paper as a paramedic, I'm looking and saying, you know, they had me at the line that the patient was subdued and in the custody and control of the police. At that point in time, great. You know, I don't see a need for me to start pharmacological intervention. I mean, that's, you know, unless, and that's as you know, black and white as I can make that argument. And there are a million shades of gray, not to pull, you know, TV into this, but there's a million shades of different ends of that black and white spectrum. But the bottom line of, yeah, go, no go, you know, give him a shot is, well, is he under control and is he a danger to himself or others? And the guy is, like, he was described as a very slight man, you know, 100 pounds, 120 pounds, and, you know, in control of cops. And I hate to sort of, you know, push my my fellow EMS workers under the bus there, but I'm not sure what other part is to be discussed after that.
I think the part that needs to be discussed is not the details of this particular case, but whether or not we should legislate medical care.
Yeah.
I think it's always a mistake to legislate medical care. I can think of many instances where it's been a problem. I think if medical care was misused, then that should be addressed on a case-by-case basis.
Right. If they did something knowingly wrong, they did it, you know, out of malice, you know, that's a different story.
Right. You know, there is a temptation.
Oh, no, I'm sorry, Dave. I mean, I understand where you're coming from in terms of this is a medical situation and it needs to be handled through the proper medical channels, as if any, you know, medical mishap would have been.
You know, there are so many points here. We tend to work with police often. We work side by side with police. But the thing to remember is we don't work for the police. Our guidelines are different than the police. Our mission is different than police. As you pointed out, you felt that maybe the guy was already under control, and maybe he was, maybe he wasn't. If he was handcuffed and therefore not a threat to others, but struggling violently, he remains a threat to himself. Mm-hmm. You know, I mean, the whole point of dealing with sedation for agitated folks, there is the safety to others, there is the safety to ourselves and the safety to the patient. I have seen patients who were violently struggling, who were handcuffed when we received them, and handcuffed during transport with police transport. And the consequence of not sedating them was they got rhabdomyolysis, their kidneys shut down. You can die from that. I mean, that's not unique. The whole point is not to wait until they wear themselves out. They can have anoxic events that they create for themselves. We've seen that. So there are many good reasons to sedate people. There are a smorgasbord of pharmacological agents we can use to help sedate people. I went back, I pulled up some great articles that originally said, let's look at haloperidol. I have a friend who says he uses haloperidol by the 55-gallon drum. He says he loves haloperidol, how it works.
Upstate New York uses it, and they were using it.
Yeah, my experience with haloperidol is that it doesn't work fast enough for my satisfaction and for the patient satisfaction, because they continue to struggle. Midazolam, I kind of, but my partiality is irrelevant. There are tools that we should be allowed to use. And when we prove ourselves, if we do prove ourselves unable to use those tools appropriately and consistently on a profession-wide basis, then perhaps they need to be taken away, even if it's just locally. If you have a place where they have endotracheal intubation, but they've had way so many undetected esophageal intubations, and you want to say to them, listen, endotracheal intubation is gone for you guys. We're going to use King tubes. We're going to use LMAs. And that's the way it is, because we've tried to get you guys on, when I say guys, I'm talking men and women. We've tried to get you guys on board with the right stuff to do. It doesn't seem to be something we can fix, either by the nature of our demographics, the nature of training, resistance to training, or maybe just geographically. It just doesn't work here. So we're going to use these other tools, and that you can apply that to ketamine. But ketamine is useful in a lot of places. And, my thought is it shouldn't be legislated. There was a study in New York State about sepsis. It's called the New York State Sepsis Study. And unfortunately, New York State responded to that by legislating the assessment of sepsis using the SIRS criteria. SIRS criteria has moved to be obsolete. There are aspects of SIRS, the systemic inflammatory response, that we can't really use on the ambulance. Certainly back when they first legislated it, of the 4 things they looked at, 2 of them weren't relevant to the ambulance. We still aren't you guys getting white blood cell counts on your patients?
Only if I have my home test with me.
Yeah. When I have my tricorder, I get everything.
Right. But, but you're in Long Island. You can afford that good.
We have one on order. They're back ordered now because of the
in New York City, we use the divining rod, so it has about the same level as finding water. So have white blood cells.
The consequence is that they've legislated this assessment, which has become the mantra in New York State, and so everywhere I go, in the hospitals, they're looking at SIRS. In the New York State protocols, they're looking at SIRS. But in 2016, critical care doc said, SIRS gave you too many false positives, too many false negatives. You could flip a coin and get the same results. And maybe we should be using Q-SOFA, which is what they recommend. And, I think that's where we should be. But they didn't change the legislation. And I would bet some of you, Josh, might be around. No, you were a latecomer in the game, right? You didn't do this when you were 12 years old. I remember when they they put in the protocols how to do CPR. And I remember back in the 70s and the early 80s, we had like CPR changing every 2-3 months. We were doing 60 compressions a minute. We were doing 5 to 1, 15 to 1. We were giving 4 stacked.
So when did you give up the barrel? The barrel roll.
Yes,
where you put the body
right.
over
we gave up the barrel when we found that putting them on horses and having the horses run around with them. Anyway, I think legislating medicine is a huge mistake. That's what I think. I think medicine should present its guidelines, and that's what I think.
Do you think that these guys, the charges being brought is more of a thing because of the Black Lives Matter stuff, and then trying to get as many people to blame as they possibly can? You read the article, they talk about the bullies with badges type thing. So they want to try to, get as many people charged with this person's death as possible. To have some sort of accountability for it. But I think, like you said, the charging these guys with the criminal act when we don't know the whole story, like Josh said, even the signs and symptoms of the guy, like you were saying, Dave, right? Maybe, he was still struggling, even though he was restrained. Maybe there's vital. What were his vital signs? What was his skin temp? All this type of stuff that you don't know. And then what are the protocols for in that area? What are the protocols? How much ketamine can they give? For patients, is it medical control? Is it standing order? All this type of stuff that you don't really know. That went on, and what drove the medic's decision process, and now how is that going forward with other people? How is that going to end up? EMS care, if you start seeing this happening more and more and more, where they're using, trying to find somebody to blame for an error that might go on, in EMS, you're going to have people who are going to be like, you know what, I'll just put them on the stretcher and I'll get them to the hospital in one piece, and then I don't have to worry about.
And that's not good medicine either. That's not good.
No, it's not. Either. That's the problem.
Now, but the other thing is that we have to look at. Listen, we are not. Our country is not without social problems, okay? And so you might want to say to yourself, have we equally applied the guidelines of agitated delirium, our interpretation of that, which is to some degree being said, listen, it's being applied to Black men way disproportionately than to other ethnicities, all right? If that is the case, if it's being applied disproportionately, if we are biased in our assessment, that needs to be addressed. And maybe there's truth to it, maybe there's not. I don't have all the stats on that, but if they have gathered the data on the application of ketamine in the field, and they do a racial analysis, and they do a geographic analysis, and they take a look at age, and they take a look at gender, and they find that, like in other places, and I don't need to name the places where people are being pulled over, you hear it all the time. The problem is I was driving while Black. They get pulled over for no reason, with the idea that maybe they'll find something in the car or they'll find something wrong. Maybe there are social, and I'm not saying there aren't. I'm going to tell you, I'm pretty sure there are social injustices in this country that are being inappropriately applied, and that we need to go back and apply them correctly. But all of medicine, all patients should not suffer from the fact that these guys might have messed up. And if they didn't mess up, I don't need to apologize to them. Then our system messed up in charging them. But if they did mess up, now when I only read the articles, I don't have everything. I have journal articles on ketamine and its use with agitated delirium, but they said they administered a dose which was appropriate for a 200-pound person who only weighed 143 pounds. I got to tell you something. That's a pretty dramatic error. Now we don't have a Breslau tape for that. We probably you can probably tell me we have it on Long Island. We don't. Not all of the ambulances, when you put the patient on, comes up and says, you zeroed it out, and this patient weighs 143.7 pounds. You
don't have that on your stretchers?
Some of the stretchers.
Really? I'm surprised that it didn't make it out.
Some of the stretchers, not all of them.
Oh, wait, that's the hospital bed. Never mind.
Yeah. So but we deserve it too. Our patients deserve it too. If we could get it, if it would be affordable, it would be wonderful.
It'd be a great thing. I fear in some respects that we're going to cycle back to one of the old standards that we go of how much of a broken system we have. Because I was thinking, when we got updated to, and we talk about that, I mean, there are aspects. Listen, for us to comment on law enforcement is only like a third-party comment. We work with law enforcement. We're out there in the field. We depend on law enforcement. There's a lot of aspects where we meld very well with law enforcement. But has law enforcement have some issues with their own training and the biases that are embedded in their training? Absolutely, you betcha. You think EMS has biases? Absolutely. But, I was laughing because I was thinking of the ketamine part. When we integrated ketamine into our protocols in New York, I was thinking, I wanted to make a comment, Dave, of how many hours did you spend in the classroom with that update, talking about excited delirium and where a patient, the counter indications of ketamine and, when to give it, when not, when to, what are appropriate doses, because, I must have spent a good, 16 hours, 2 days doing that. Or is that, fantasy?
Yeah. Well, listen, I think it's, I think we brought a few highlights to it. Like you said, we don't know all the details, and we're going by 1 or 2 articles that we've looked at. I just wanted to kind of touch on it a little bit because I wanted to, just kind of get your guys' take on, like you said, the legislating the care like that, and not addressing what could be a medication error versus, something that was criminal where they were doing something, trying to do harm to somebody, and there should be consequences, on a medication error that caused somebody to die, of course, but I don't know about a criminal charge, for them. But with that said, I wanted to kind of segue into the other topic I wanted to talk about, especially we're talking towards the end of this conversation about bias and treating people. And there was this article that was in EMS 1. I put a link in the notes here if you guys saw that or not, about transgender patients and treating them and all. And I just found it interesting with that that article, because for me and other people that commented in the comments on that article, especially on, I think it was Facebook, where they were like, it doesn't matter, right? If what the patient is, your treatment for most patients is going to be the same, whether they're male, female, or otherwise, right? You're not changing anything for a heart attack, person having an MI based on whether they're transgender or not, and I feel like that I don't know. To me, I felt the article was just self-serving and putting something that was popular in the mainstream, to kind of get views to their website, and I just I kind of got into it with the person that wrote the article a little bit.
Jim, no.
But I just, it's just this whole mentality of, I'll tell you a story. Years ago, I can't remember the name of this place. It was a famous sort of club hangout in the Village, and we got called there for a difficulty breathing patient by the BLS crew, and we get there, and it was a person who was transitioning from a man to a woman, and they had breast implants done, and one of the sutures that were there had popped, and they had like a little hole, and they were freaking out. So they were actually they were hyperventilating more than anything else, right? And all their friends are in the back of the truck trying to, console her and do all this stuff. And for me, I felt that it was difficult because they give you the person's driver's license and it says, John Doe instead of Jane Doe, and you look like the person, they look like a Jane, right? And you're like, okay, so how do you address the person when nobody's telling you the information, right? You're looking at the person, by their appearance that, okay, this looks like it's a man transitioning to a woman. You don't want to offend them. You want to call them by whatever it is they want to be called by, a name or whatever. And nobody's kind of giving you the information as the provider on scene on how to address somebody. So you're kind of guessing what to say and what to do, without trying to insult somebody or be incorrect in what you're saying, you know. And I felt in that situation that it was hard for me to what am I documenting, male or female? What am I writing in my comments, male or female? You know what I mean? And it was a challenge to me for that. Nowadays, people are more forthcoming when you interact with them, and they'll tell you, what they want to be addressed by and whatnot. So it's a little easier now. But I'm just wondering, really, how much does this affect what we're doing for patients? No matter what gender they are or how they identify or where they are, if they are transitioning or whatever, how is it affecting how we're treating them? Is there any change other than what we're calling them or what we're saying to them?
So I think there's something to it. I don't think there is I don't want to quantify it. But I ask people when the first day of their last menstrual period was. That's always important, for people who get their period from like 8 to 60 years old. I'm asking that question because it's relevant. If they're getting hormone therapy as a person transitions, I think that's relevant. I don't know all the consequences of it, but I know that there are consequences of it, So I think that there are some things we presume that are gender-based, just like there are trends within ethnicity that might be relevant. By the way, I wish the forms that we had were better than male-female. I mean,
well, they haven't been changed.
If we looked at,
haven't been changed in 40 years,
right? If you're a trans man, there should be trans man. That should be easy enough. And even for trans man or trans female, trans male, trans female, there are gradations along the way, to complete and partial transgender transitions. So
I'm sorry, Dave.
I'm just thinking that, there needs to be some statistical look. You don't know if you have a problem if you don't measure the problem.
Right.
So I believe there's something to that.
We're looking at sort of two distinct issues here. One is patient interaction. How do you interact with your patient? How do you put them or try or have the tools to put them at ease so you have a better rapport? And we all know a good rapport helps the medicine. And then there's the other aspect of the medicine. And I think that, and I was going to say, and I'm glad that you said it, Dave, is that, there is sophisticated medicine in the more advanced cases of people transitioning to another sex. There's hormonal therapy, there's surgeries, there's psychological. I mean, there is just the gambit. And it creates a very complicated thing. Now, throw into that the New York, and I'm sure other cities have a famous club scene, but that's where I cut my teeth. That's where I started as a paramedic, and the drugs that we would GHB and ecstasy and all of these others on top of that create something that we have to have in our toolkit when we're going into that environment. But I think the important thing to take away when you're dealing with these, I wanted to say the new normal in EMS, and it's because, but it's not new. There's nothing new about it. This has been going on for many years. Is that how do we differentiate with those patients? And I sort of have always used the playbook of, if you're presenting to me as a male or a female, or you're trying to present a different than what you are, my rapport with you is going to be based on how the effort, what you're not the effort, but what you're putting forward to me. Are you dressing as a female? Then I'm going to address you as a female, unless you tell me otherwise. And if I'm confused and the patient's alert enough and everything else, I'll ask them, what do you want? How do you want me to interact with you?
What I have found the problem is that I'm gonna be honest. It's like I feel as if sometimes when someone is transitioning or whatever, they almost don't want to tell you where they're at. Meaning, let's say they're going from they're a woman, they're going to a man. They still have a uterus. You know what I mean? And you need to ask them if they're having an issue with abdominal pain or something along those lines. When their last, menstrual cycle was. You need to find out, is there a chance that they could be pregnant? Things like this, and it's almost like they don't want to answer those types of questions, or they don't want to be very forthcoming with that. They want to sit there and they want to identify as the man. They're going through transition as the man, and they don't want to address the fact that what could be happening to them is female in nature, right?
Well, you're not.
So you unless you are, and what I've ended up having to do is like Josh said, I try to address them as how they want to be addressed, and I treat them how they want to, because of how they're presenting to me. But if their medical issue is something that is, would be a gender-related type issue, then I end up kind of dancing around the topic to get them to be forthcoming with the problem, what's going on. And then if they're looking at me like, what are you talking about? I'm a man, and you're really not fully transitioned. Then I end up saying, being blunt with them and asking them blunt questions, because then time becomes of the essence, and what I'm going to do or not do for them is going to be based upon what the information they're giving me is. It's just that the patients you get that you get in the house, you're asking 20 questions to them, and they don't want to tell you that they have HIV, and then you get to the hospital and that they tell the nurse, "Oh, I have HIV."
They have a right to do that. I think we have an obligation to clarify things as best we can, and I think until we get a lot of practice with it, I make my students, every student in the class, especially the guys, especially 17, 18-year-old guys. You know how many people they've asked about the first day of their last menstrual period? They can't even get those words out of their mouth, half of them. So I make them do it. And until how many times did you put on a traction splint in your EMT class? I put it on like 30 times. I'm good at it. How many times did you ask women about their menstrual period? This many times. For those of you who can't see, I put up the 0. No, we didn't do it. And until we get good at it, until we teach people to do it, we need to do our own research, because we can't get updated on everything. I think that the article actually offers a really great line. May I ask some clarifying questions so I don't miss anything medically necessary for your care? I think that is a beautiful line. A beautiful line. I love it. I put that with the questions that I ask people when I want to know if they've been abused. I ask them once and only once. When I see people with injuries like yours, sometimes it's because people have hurt them. Did anybody hurt you? That's an easy thing for me. I've rehearsed it. I didn't even make it up. I got it from a physician who specialized in domestic violence. And I make my students learn that line, and I make them use it, because the first time you ask shouldn't be the first time. We should have done it in training. And the other thing is, how important is gender? I'm going to tell you, every report you've ever given, every doctor has ever given, it is the second piece of information.
Right.
When you're calling the hospital, I'm en route to the hospital with a 56-year-old or an adult male, a 56-year-old male, a 72-year-old female, a pediatric female. It's the second piece of information we are taught to give, and we give it without question whether or not it's relevant. It's interesting we never questioned its relevance before, and that we're questioning.
Well, isn't that part of the unstated flow chart that we have? I mean, you know, I never turned a page in an EMS guideline, in the EMS book or textbook that had the flow chart of, you know, you start out on the scene. You're on the scene. Okay. BSI. Yeah. We discussed that in all our classes, but it's not on that flow chart. You're looking at, and the first thing that comes to mind is the age or the development of, and then gender. And, you know, split down.
And racial.
And then this aspect, male, female, is there a break in that tree? No, it gets complicated at that point because there are some things you have to do for everybody and some things that are specialized to the sex. You know?
But when it comes to what we're doing for the patient, right? There's nothing we're going to do for them if they're transgender that's different, right? If they are a male or female,
unless they're pregnant, then medication.
They're a female. Then they're a female.
But my decision on medications to use, some medications are not good for pregnant women or for pregnant transgender males, because that has happened too. That has happened too. That women transing to male have become pregnant. And therefore, if I'm going to give them midazolam, if I'm
still a woman, though, you got to treat them like you're treating them like a female.
I'm treating the fetus, and I need to know if there's a fetus.
Right. So there are important.
I don't think it's an everyday event. I think what we need to do is make this smooth and easy. If we always do the right thing, if we always ask them, what gender are you identifying with, you know, or that great quote that I had before, which was, may I ask you some clarifying questions? Because as soon as they say they're a man, I identify with man. The question to say is, are you a trans? You know, is it a transgender man? Because it becomes relevant. I think it becomes automatic.
And one of the things that you just sort of alluded to before, Dave, is that we don't get all the information. That sometimes happens where we'll roll into the ED and they say, yep, I'm HIV positive to the nurse, where they wouldn't tell you anything.
Our medical history is awfully deficient sometimes.
If, you know, our job is to apply first round medications and first round medicine in the field as early as we possibly can to help, you know, in an emergent situation. Can we always do it? No, we can't. Sometimes we're reduced down to, you know, the only medicine of choice is diesel, and we get them to the emergency room.
Well, the only thing that I would say that is, like Dave said, you know, the male female thing is one of the first pieces of information that we relate to the in our report, whether it's verbal or written. It's one of the first pieces of information we try to gather. And if we're getting stuck, because people will get stuck on that, right? They will sit there and try to figure out what somebody is. Meanwhile, there's something else going on that now you're so caught up in trying to not hurt somebody's feelings and to you know, to address them a certain way that you're not treating the medical problem that's going on with them. And whether they're transitioning from, you know, a man to woman, woman to man, if it's a woman that's becoming a man and she's pregnant, I'm sorry, you're going to be treated as a female who's pregnant. There's no special.
Well, we don't have to say that. We can simply say we're going to treat you appropriately. I'm going to do the best I can to take care of you. Can a trans male have an ovarian cyst?
What are you going to write in your paperwork?
Well, there you go.
22-year-old pregnant male.
Our paperwork is deficient. The paper should not define. Again, like legislation should not define. A form shouldn't define good medical care. If the form needs to be fixed, it needs to be fixed. I'm stating for the record right now, everybody, the forms need to be fixed.
But there's an aspect in the form where we have a free flow of
narrative.
A narrative, right?
The narrative doesn't come up in
the narrative is where we put that. If it's important enough, we give it verbally to the nurse or the doctor in the ED.
The narrative
I think we're sort of addressing another thing that happens very often in EMS, which is tunnel vision or getting stuck on a particular idea or subject. We really need to sort of keep that. You said no?
No,
he did say no. Oh, okay.
Oh.
So
Go ahead, Dave.
I think putting it in the narrative is a stopgap measure until we get it in a data
True.
field, because you
Right.
can't measure. We don't measure narrative well. We don't, if you put all of your assessment in the narrative, which is very nice, you can't really do a good assessment. How did they do on abdominal complaints? Well, if we have a field that's abdominal complaints, we can pull that up real quick.
Let me go way basic. That has been there for 100 years. I'm sure it's been there since you started EMS, Dave.
100 years ago,
the
yeah,
checkbox of ethnicity. Ethnicity.
Yeah.
White, black, Hispanic, whatever. Now, I am pretty sure that all of you guys check those boxes, right? All the time on your paperwork.
I do now, just to let you know.
I love that. Hold it. But that's exactly where I was going to.
Right.
Because there was a point when I didn't, because I thought, well, this is insulting. There shouldn't be any difference, and we shouldn't be studying the differences or understanding everything. And I actually had minority partners who felt the same way and refused to check that. And I, in a form of solidarity, did that until I met a doctor who was doing research and pointed it out to me and said, what the hell? He said, this is critical for me. And I'm like, because there are a lot of things that we don't know that goes on in the research behind our paperwork. And our job should be to fill out that paperwork as best they can so they can collect the data as best they can. But we have things like that translate from biases in the field that we don't want to incorporate into our lives. And we're actually doing it in the wrong reason.
Hey, and Josh, the only way we can show that we are unbiased is by showing it. For example, wouldn't you be horrified to find out that Jewish men were being treated, when they presented with kidney stones, were being ignored for their pain?
That would be, it would be as bad as any other.
Yes.
It would really be.
Yeah,
Anytime I find
chose
those,
that because I don't see that
Right.
as a likelihood. But
Right.
do you think that if we looked at some of the minorities in this country who may or not even be minorities now, the non-white populations, do you think that they're getting treated for their pain similar to a
well, I know they're not. Listen,
what?
there was a famous study a few years ago. Yeah,
and if you don't measure it, you don't know what you do. You can't prove you're unbiased until the data shows you're unbiased.
Listen,
and
I did my rotations in a Catholic in a strict Catholic hospital run by nuns. I know. And the problem was the slaps with the ruler on the knuckles, because you had to write fast enough and your penmanship. But besides that, when I was doing my rotations, on every floor in the nurses' station was a laminated 8x10 piece of paper that basically said your patient has a right to pain medicine. Withholding pain medicine does not help the healing process. And it went down that line. And it was the fifth vital sign is your indication of pain. All of this stuff. Where would you find in a modern hospital that people would have to be reminded to treat other people's pain?
And how about pediatric treatment of pain? That's a big topic. We don't treat that well at all. Also in the ER, they don't treat it well at all. The statistics show that, and there's an effort to correct that. But again, if we don't measure it, if we don't measure gender, if we don't measure ethnicity, if we don't measure age, if we don't measure all the things that we've been talking about, we don't know if we're doing a good job. We don't know if there's inherent bias, and then there are gender-based, ethnicity-based conditions that need to be considered. Does it matter if somebody's Asian? Well, it does for Brugada syndrome. Does it matter if somebody's Jewish? Yeah, it does for Tay-Sachs. Does it matter on skin color? Well, it does for sickle cell. So these things matter. There are trends. It matters for diabetes. It matters for hypertension. It matters for nutrition. There are, we know that there are are deserts. Vegetable
David,
deserts.
it matters, but
that's why we have a discussion.
How about
it's not about it mattering. I feel like the treatment for those patients is going to matter, right? Because of the different their ethnicity or a certain that they have in their culture or whatever. But when you're talking about when you talk about transgender, right? What is mattering? What's going to be the difference one way or the other?
In cardiac arrest, nothing. In the treatment of pain for a person who might be carrying a fetus, something.
Right, but at that point, you're asking the person's obviously going to be pregnant, right? Or you're going to ask them, are you pregnant? When they say they're pregnant, you're not treating them as a male.
I understand, but if you
right?
ask them
so
their gender,
matter
or you think they're a male,
what would matter more for that person would be more of things like you said, their skin color or their race would take more of an important line than them transitioning somewhere.
In the literature, they even talk about having an organ inventory. If you want to go down and say, how.
Yes, I've seen that too. Right. Yeah, I know what you're saying.
So,
but the thing is that, when you're interviewing the patient and I mean, for me, it's like, okay, well, can you be pregnant? Are you pregnant? That's an important question, right?
But you don't want to ask. You probably wouldn't ask that.
You're going to ask that question because you're thinking the person might have some side of a female medical problem going on.
But what if you don't have that suspicion because they look manly and they are pregnant?
Well, this is when it comes. This is on the patient's, side.
You want to say the patient
just like the HIV thing. It's up to them to owe up to the fact that
wait a second. So, Dave and Jim, we're getting a little bit into that narrow focus, a little bit into the tunnel vision, and I need to pull us back because I'm going to say there are certain things that we may not, and we should be used to this as EMS providers, that with certain information we may not get or get accurately when we're in the field, and we have to use our best judgment. And
for Josh, we use our best judgment and our assessment and stuff like that. But if the patient's not going to assist us in the assessment process, if they're conscious and alert, and they're not going to volunteer, they have abdominal pain, let's say, and you think they're a man, you're treating them like a man, and they never come out and say to you that, well, I'm transitioning, I still have a uterus, I just want to let you know, maybe is something that is that a problem, or that could be something that's going on.
Well,
if
but
you're
that
assuming
should
it's all man, related, it's like, it's like shame on them for not telling you what the hell's going on.
What's your forget about shame on them. What is your treatment for abdominal pain in EMS?
You know what?
I mean, how often do you give pain management for abdominal pain in EMS?
We do. I do.
Yeah,
I do.
You do.
I give fentanyl for abdominal pain. Done deal. That's in my protocol. Done deal. You know why? Because I have a right to pain management.
Right.
Yeah.
All right. I heard somebody say that just before.
Yeah.
As far as the relevance of information, we ask patients on a regular basis, do you have any metal in your body? It's not going to change one bit of my treatment, but it will in the hospital. We get pre-hospital irrelevant information from our patients as much as we can. So if they lose consciousness, it's there already.
We have as much to go on as we possibly can.
So we get what we can.
Exactly.
And mastectomies influence blood pressure acquisition, IV access.
Just like if they have breast cancer, right?
I said mastectomy because I wanted to be generic. Yeah, there are women getting mastectomies as they trans to men.
Right.
Right. So this is what I'm saying, is that
But it matters where I start my IV.
Unless it's obvious to us as providers that they're still transitioning. Like Josh said, you think they're presenting as a man, they look like a man. You don't think for a second that at any point they were a woman. If they don't come out and tell you, I had a vasectomy, and you know what I'm saying, that you're going to be treating the patient like a man, and you're going to get weird blood pressures or whatever, and then.
So how many women have you gone to assess, and you put the BP cuff on their arm and they say, oh, no, you shouldn't take it on that arm. Now, some of them don't tell you that. And then as you go through your history, you found that you did. Now, I'm not saying we haven't killed people for doing that. How many times have you gone to start an IV on somebody? You get the IV and then you find that they had a mastectomy in that arm.
Right.
So should they be forthcoming? Yes, but there is no test that you have to take to become a patient. You are a patient. If you fog a mirror or don't fog a mirror, you are a patient. There's no standard food, oh, I'm a good patient. Some of them are great. They give you the history. You show up. I ask every patient, because it's one of my choice things. Hey, listen, I need to take a blood pressure. Is it okay if I take it on this arm? That gives them an opportunity to be more forthcoming.
Yes. And I think, like you mentioned before, Dave, having one or two questions to ask people, whether even if you don't suspect, unless they're some 90-year-old woman that,
they're pregnant.
Yeah. But to ask certain questions as to give them the opportunity to be forthcoming if they are transitioning or they already have transitioned, and some type of questioning that you can say that wouldn't necessarily offend them but would elicit the response you need, or give them, like you said, the opportunity to say, I've transitioned and I still have a uterus, or I still have a penis, or whatever, so that what it is that you're dealing with, what you should be looking for, what you should be not looking for, what you can expect on certain treatments and interventions and things like that. Or even like you said, Dave, and the occurrence where you have somebody who's transitioned to a man and they're pregnant, right? So what it is that you can do, for the patient.
I don't think this is easy. And I think this listen, there's nothing we add to our culture that makes things easier in medicine. I can't think of anything that has made it easier as we've gone along from when I started in the 70s to now. It's only gotten more and more complicated. And as that happens, we have to get better and better. If we always do what we've always done and things change around us, we've made a mistake.
Right.
I think we need to consider whether or not the things warrant a change. And if you've never considered it, at least listening to what we said today and my listening to you guys makes me better, so that, number one, I'm not surprised. Number two, if I find I need to come up with something, we've said it. We've had great stuff. And I think from the psychological point of view, Jim, which you started out with, I think early on, a person likes to be referred to in the gender they want it. A person who's transgendering wants, it's not casual. Listen, I'm a guy. Been that way forever. Right. It's easy for me. But you know what? It wouldn't be easy for me if I had been a woman for the last 60 years. And now I am finally, if I've made the decision after 60 years, 40 years, 30 years to go across, it's an important issue to me.
Let me add to that, Dave, is the flip side of that conversation is you're a guy. You've always been a guy. You're used to it. You're a husband, dad, and grandpa, right? All of that good stuff, guy. I get you into my ambulance and I start to refer to you as ma'am or miss. How's that going to make you feel during transport that you're in good care, good hands?
It's the presumption that is the issue.
Right.
If we don't ask, we don't know. So we should ask somewhere along the way. And I believe it's early on. We should ask, how do you want to be, what gender do you identify with? Let's start with that. That's a great question.
Let me let me add another little.
Listen, you guys got beards. Would you be offended if I asked you that question? What gender do you identify with?
No, I
It
wouldn't.
depends upon the day, because some days I get
But you know, the
You've
funny
had your
thing
coffee
is,
already.
have
I
you
get a
ever
little
had
emotional.
have you ever had the ambulance call where you got the little old man in the back and he had somewhat of a beard, had somewhat of a mustache,
The
and
little
that
old woman in the
man-
back who had the beard and the
Yes.
mustache.
Yes. Yeah.
So the question is, what
I'm
do
like,
we do
I
about
usually
that?
say, doesn't anybody give you a razor in that place?
My mom asked for a razor and tweezers.
Tweezers. That's the way to go.
I'm
But
just
that was
saying.
to clean up your beautiful baby face.
Not for me. She asked for it for her when she was in the when she
They
was
didn't
in
give
the
it to her?
nursing home. She did. I guess she didn't want to ask them. She asked me.
Oh, okay.
And you know what? If she didn't want to ask them, that's fine with me. I'll take care of it. It took me like I'll be there in 45 minutes and you'll have it.
Yeah.
The consummate caregiver.
Not really, but I think I'm better with patients than the people around me.
Oh my God. I've been told that about 1,000,000 times.
Come on, you know, if Jim came to my house and I called for chest pain, he'd be having me walk out of the building holding the oxygen tank.
And the life pack.
I call it the Hoffman stress test. It hasn't been documented or in publication yet, but someday.
There is a Hoffman apparatus. You familiar with it?
No.
Yeah, it's for separating water into hydrogen and oxygen. But all right.
No,
I digress.
never heard of that.
Don't do it on your patients; they'll disappear.
Yeah, back to the divining rod we talked about before.
You can look it up afterwards. Maybe one of your relatives developed it.
I'm thinking
Elijah Hoffman.
I'm thinking one of my relatives own Hoffman Car Wash franchise in upstate New York.
Cola.
I'd be happy with that.
Hoffman soda.
Well, isn't that
Hoffman
where
soda? That was my big thing with my dad growing up.
Isn't that
You always
where
say
you
last name and say Hoffman
he's
like
my
the
age,
soda.
right?
So the
Jim,
car wash, Jim, isn't that where you hide the extra money from your meth business?
Yeah.
Okay.
Oh no, that's Breaking Bad. Sorry.
All right. I think we have. I think we're melting down from too much.
Yeah. We'll end the day.
I
I
need more
wanted to
coffee.
do one other thing, but we've been going for an hour, so I'll save it for another time. Yeah. So
Jim, I want to thank you for picking these. These were great topics.
Yeah, I just wanted to kind of get your guys' feel on it, because I see so much back and forth in the comments and discussions going on social media, and I feel a lot of times people go on social media and they make comments and they're not really, because they're hiding behind the comments, they're not visual and there's not an audio component to it, that it's hard for people to get some of their thoughts out when they're just writing it in text. It never comes out the way you think it's going to. And I think people sometimes when they comment on social media, the way it comes off is different than what they wanted it to be, So I wanted to just kind of touch base on this type of stuff, and maybe we'll revisit it in the future. All right, guys, that's it. I'll end it there. Thanks for joining us, everybody. As always, I am Jim Hoffman.
Josh Knapp.
Dave Brenner.
Stay safe.